All right, great. Okay, so today we're going to talk about a problem in biomanufacturing, or manufacturing of biologic pharmaceuticals. And particularly, we're going to talk about the connection between adverse events or side effects and the manufacturing process for these pharmaceuticals, and whether there is a connection at all between these two issues. And so the reason this is an issue that's interesting for us to study is that currently the way that the FDA and the whole academic and industrial complex studies the relationship between biologics and their adverse events is primarily by looking at large or unexpected clusters of these adverse events that are very obvious, maybe some sort of major contamination event at a plant or something like this. And there's really no sort of weak signal or trending analysis that's done of adverse events unless there's one of these major issues. And so the underlying assumption here is that as long as a company's manufacturing process is operating under FDA approved control limits that are specified when a particular drug is granted FDA approval, then all of the adverse events or these side effects are driven by differences in drug-patient interaction. So you might have some patient that was predisposed to a particular type of adverse event from a particular type of drug before. And indeed, much of the literature is devoted to studying the relationship between different patient populations and different types of these adverse reactions for different drugs, making sure that the manufacturers and the FDA are aware of the different types of side effects that different types of patient populations can suffer. And that this is great. There's lots of, this is difficult, but there's a lot of people that are working on this problem. What's missing from this analysis is any sort of method for detecting recurring weak signals of lot to lot or batch to batch variability that could be related to manufacturing or supply chain issues related to these drugs. And so that's what we've been studying, and that's what I'll present today. And I'll present an application of this method to real data from an industrial partner, as well as this public data set. And this last bullet is not nearly as trivial as you might expect. And the reason that you might initially suspect that manufacturing or supply chain variability could be contributing to some sort of variability in the quality of these products is that when you manufacture biologic drugs, it's quite different than manufacturing a simple tablet or a simple pill like Tylenol or aspirin. These simple drugs are manufactured in a very controlled setting, and they're chemically formulated so that you are essentially able to make exactly the same product every single time. The drugs that we're studying are drugs that are actually grown in living cells, and the manufacturing process involves genetic modification of these cells to produce a particular type of antibody that are then grown in these large vats. And so this is an organic process, which means that there's all sorts of natural sources of variation in the product that you get. Each lot of the product you never get the exact same product in two different lots of the product. And so that's what sort of makes it interesting and what motivates this sort of analysis. Okay, so I'm going to talk about some of the data that we've been using, as well as some of the methods that we've been applying to model patterns of adverse events in sequences of manufacturing lots. And really, this method is designed to determine an answer to the research question, which is there any sort of pattern that we can pull out of sequences of adverse events that would indicate that there is some sort of sequential dependence in these adverse events that you wouldn't expect if the source of these adverse events was purely drug-patient interaction. And so we're going to also interpret these results and discuss what they mean, and broadly what the application, the case study means, but also what this method could mean for the FDA and for the pharmaceutical industry as they look at new ways of monitoring the quality of their products. Okay, so I am going to start talking about some of the data that we've been using and the methods that we've been using, but I'll pause before I do that and ask if anyone has any questions on the problem setup. And I apologize that I can't see my Zoom with these two windows open, so feel free to just shout it out if you have a question. All right. Okay, so the first step here is defining a data set that we can use to try to answer this question. And then I'll get into the methods that we use to answer the question as well. And this is actually a bit of a challenge because the pharmaceutical industry is extremely rigid with their proprietary data. So we do have public data from the FDA that reports self-reported adverse events, and these are self-reported from healthcare providers and from consumers, and we have access to this on a public system. And we have about 30% of these reports connected to a lot number, and that lot number is the same lot number that the manufacturer uses to refer to the product internally. And so what we've been able to do for one particular product is match this lot number from the FDA to lot metadata that helps us sort of understand characteristics of the lot that are really important to doing our sort of modeling. And the main characteristics I'm listing here. So we know the lot size, so we know how many doses are in each lot, and we know how many adverse events are in each lot. And then we also know a way that we can order these lots and how they're related to each other. So we know the packaging date. And then we know a little bit more information like the dose form and where these lots are distributed to as well. And that meta information will become important as I go. And so what we can get out of this information. Oh, sorry, someone had a question.
Anything about the production data? You just know the lots. How many?
Exactly. Yeah. So this is one of the limitations that we have right now. So we have a very limited amount of information about the lots themselves. For a year and a half when we were working on this project, we didn't even know how many doses were in each lot. We didn't even know what the size was or the packaging date. This has actually come only within the last 3 months or so. So yeah, and actually the structure of the model, I'll talk about this as sort of an extension, but the structure of the model and how these lots relate to each other is somewhat constrained by the amount of metadata we have about these lots. So we know sequentially when these lots were produced, but we don't know whether they came from the same batch of raw materials or if they're connected in other ways. So this is what we know. And so from this, our data set that we're going to use is actually 4 different data sets. We separate the lots that we have information about into 4 different dose forms. So as we've been interacting with an industry partner or manufacturer on this topic, we've learned that the dose form that a drug is delivered in really matters for the types of adverse events and side effects that are reported. And this sort of makes sense. So when I talk about dose forms, you can think about a drug that's delivered in liquid form could be delivered in a vial that has a syringe associated with it, or it could be delivered in like a pre-filled pen. So you either administer it yourself or maybe someone else administers it for you. And so if you're administering the drug yourself, you might have a different type of adverse event than if someone else is administering it for you. So these define these different dose forms here. What these dose forms actually mean is not really super relevant to understanding the analysis. The universe of data that we look at is data from between 2011 and 2019 distributed to the US. And we look at adverse events that we classify as serious. And by serious, we mean serious side effects that are identified on the package label of the drug or they are clearly serious reactions. Yeah, I do have a slide on this here. So on the bottom here, you can see that hospitalization and death and loss of consciousness. These things are noted in the database. So there's some debate about exactly what type of adverse events to include in this analysis, but the main takeaway here is that serious adverse events are what we are considering. And, okay, so I'm going to talk a little bit about the modeling now. And so just again, the research question that we're considering is there a pattern in the number in the adverse event rate that we see in these lots that exists in a way that you would not expect if the source of the adverse events was simply drug-patient interaction. Now, one primary assumption that we're making is that lots that were packaged at similar dates were manufactured and distributed under similar conditions. And the reason that we make this assumption is to create some sort of structure in how these lots are related. So basically, we are assuming that lots that are produced closer together in terms of date are more related in terms of their manufacturing and distribution conditions. And so then our research question becomes, can we identify the presence of local? Yeah.
And do you know the manufacturing date from the adverse event data that the FDA has?
No, we know that from our industry partner.
Okay.
We can make a guess at the manufacturing date from the adverse event data. Well, I should say we can make a guess at how to sequence the lots based on the adverse event data from the FDA, but we don't know exactly what the sequence of production was for these lots. This is one of the major pieces of information that we got from the manufacturer that we're working with.
Yeah, okay, thank you.
Is there only one manufacturing site per country? Because you said that you know the country that it was manufactured in, but it could be.
So we know we don't actually know the manufacturing site in this case. We know where the lots were distributed to.
So there could be multiple manufacturing sites.
There could be multiple manufacturing sites. I think anecdotally, we know that the vast majority of this product is produced in one manufacturing site.
Okay,
but we don't specifically know which lot was produced in each manufacturing site. This is the sort of additional structure that would be nice to be able to include in a more complex model. So basically, if I go here, the structure that we're assuming that's related to manufacturing and distribution is constrained by the amount of information that we know about each one of these lots. And so that governs our decision to use a sequential model. And so we're basically looking for a pattern of local serial dependence in these adverse event rates that you would not expect to see if all of these lots were distributed, if the lot numbers do not correlate with other features such as comorbidities of the patients who are receiving the lots or regional locations for where these patients are, which we do not have any reason to believe that these are correlated. So any sort of serial dependence that we see in the production dates should relate to manufacturing or supply chain conditions. Now, we can only say that broadly. We can't say the specific supply chain or manufacturing conditions, but we can say this. A couple other notes that I want to make. The first is that a big problem in this type of analysis generally is that there's a very large censoring rate for adverse event reporting. So most of the adverse events that people experience don't get reported to the FDA. This is a problem if you're looking across drugs, because you could potentially argue that there's different censoring rates for different drugs. In our case, we make the, I think, reasonable assumption that there is a censoring rate, but the censoring rate is reasonably constant across all of the lots for one particular drug. And if you assume that it's constant across all of those lots, then it does not affect our analysis. And so since we're building a sequential model for these adverse event rates, and trying to determine if there is some sort of serial dependence. The structure for our model that we're going to use is a binomial mixture hidden Markov model. And I'll describe the structure of that model on this next slide here and why we choose it. So this is the same picture from before. And so what the hidden Markov model structure allows us to do is assume that there's some sort of unobserved risk level for adverse events that's inherent in each one of these lots. We're going to call this unobserved risk level a hidden state. And so this is just an example of how you might label these lots as having a hidden state. Just this second line here is observed for us, and from the model we're trying to learn what these hidden states are for each one of these lots. And in particular, so what is a state? A state is a state-dependent distribution. It's a probability distribution of the number of adverse events per lot, or this rate that we'd expect to see. And the binomial mixture portion that we have specified, this is telling us what family of distributions the hidden state comes from. So we are assuming that where you're using a binomial mixture model as the distribution for each one of these states, and we are learning the distribution parameters from our estimation process that I'll describe. And so the assumption behind the binomial mixture model is that that each dose within the lot is an IID trial essentially, and we have a mixture of multiple binomials, so it's not just a single unimodal distribution that governs the distribution of each state. And the key property of the hidden Markov model that we're going to exploit is that there's a particular set of dynamics that's assumed between these hidden states. So the hidden state of this second lot here depends on the hidden state of the prior lot governed by the Markov property, which means that the dynamics can be described by a transition matrix. So the transition matrix tells you the probability, given that you're in a low state, that you will end up in a high state for the next lot. And so our estimation procedure is going to learn not only just the distribution, the parameters that govern the binomial mixture distributions for each state, but it will also learn the transition probabilities between these states. And it's interpreting these probabilities and the state distribution parameters that we can infer some structure about the system and allow us to understand if there is this sort of serial dependence in adverse event rates. And so this is what we're going to look for as we look at the fit of our model. So I didn't include a slide on estimation of the hidden Markov models, but for those who are interested, hidden Markov models are fit using an iterative procedure. It's not possible to directly do maximum likelihood estimation in one shot in a hidden Markov model, because the likelihood cannot be written down in a simple way as a function of the parameters that you're optimizing. But it is possible to do an expectation maximization like algorithm and iteratively find the maximum likelihood parameters for these models. You have problems with local optima when you apply this sort of iterative procedure. This is common across probabilistic modeling. So we use 50 random restarts for in the optimization procedure to try to guard against getting stuck in a local optima. And that seemed to work fairly well. The results that we get make good sense.
When you do that, are you trying to find the number of states and also the parameters of the binomial?
Yeah, so we're gonna talk about that in just a second.
Okay.
That's actually what I'm going to talk about in this slide. So so when we set up the model, we're not just going to estimate a single hidden Markov model. So this is I would say a frequentist approach to what's behind your question, Chris. So what we're going to do is specify two hyperparameters for each hidden Markov model that we specified. The first is the number of hidden states that we assume exist in our data. And the second is the number of mixture components that are available to be fit for each state in the binomial mixture model. And so based on which of these structures provides the best fit to our data, based on this Bayesian information criteria, which penalizes model complexity and rewards high likelihoods, this can tell us something about the structure of the data that we see. So basically what we're going to do is we're going to fit a bunch of these hidden Markov models, and we're going to look at them and we're going to see which one fits the data the best. And we're going to interpret the structure of the sort of generating distribution of our data based on the structure of the model that fits the data best. So if we fit a model that has only a single hidden state, then there is no Markov transition matrix anymore. It just collapses to one. Then what you're really fitting is just a binomial mixture model for the data. And the implicit assumption there is that there is no sequential correlation in adverse event rates. There's no serial dependence in these rates. You just have some sort of variation in these rates across all of your observed lots that is due potentially to drug-patient interaction or something else besides the manufacturing or the distribution process. And the amount of variation in these other factors, let's just call it drug-patient factors for simplicity, governs the complexity of the distribution that you're going to need to use to fit this model. And so it governs the number of mixture components per state that we will need. But in all of these models that have a single hidden state, there is no sequential dependence that is present. On the other end of the spectrum, if we find that a model that has multiple hidden states, so it's now a true hidden Markov model, but it has only a single mixture component per state, if this fits the data best, then we can assume there is some sort of sequential correlation, and there's actually very little variation that's not explained by the Markovian dynamics that we've assumed in our state transitions. And we could also get a blend of both. So this is the general version of the model that I was discussing in the last slide, where you have multiple states, and each of those states has enough variation to require fitting via a binomial mixture model with multiple modes. And so the plan for our analysis is to fit all of these models to see which one fits the data the best based on this criteria that penalizes complexity, and then to analyze the structure of the model that fits the data the best and sort of corroborate what we are seeing by interpreting this model with a couple of other metrics that we'll study as well. Oh, sorry, I did have the fitting slide. I explained this slide already, so I think I'm gonna skip past it unless someone really wants to know more about EM, and then I'm happy to talk about it. But I'd like to show some results. So so this is exactly the same. Each one of these panels is exactly the same structure as the XY plot that I showed on the last slide, where we fit a set of hidden Markov models to the data for each one of these 3 dose forms. We exclude one dose form from the actual estimation process because it doesn't have enough lots. There were only 30 lots, and there's not enough lots to actually accurately estimate the dynamics there with any sort of precision. And what you see when we estimate this set of models for each of these dose forms is that for 2 of the dose forms, dose form A and dose form B, which are actually the 2 most prevalent in our database and represent roughly 80% of the lots in the data set, you see that multiple hidden state models with multiple mixture components provides the best fit for the data. So there's 4 hidden states in this best fit model for dose form A, and there's 2 hidden states in this best fit model for dose form B. Interestingly, dose form C is sufficiently, the variation in adverse events and the sequence of adverse events that we see is sufficiently explained by only a single hidden state with 3 different mixture components. And so our first inference here is that we see initial evidence of sort of serial dependence in adverse event rates by packaging date for dose forms A and B, but not for dose form C. And so we can corroborate this with evidence from another method, which is not related to the hidden Markov model, and we can look at the autocorrelation function for these three dose forms, and we get the same answer. The punchline of this line is that we get the same answer. For those who haven't seen autocorrelation functions before, it's actually a very straightforward concept where at the x-axis, you're looking at a particular lag, and the y-axis is looking at the correlation between the data measured at lag 1 with the data at time 0. So this point right here is the correlation between the data measured at time 0 and the data lagged by 1 lot in this case. Now it's slightly more complicated here. We're looking at the partial autocorrelation function, which means that each one of these lines measures the correlation, netting out the effect of all of the other lags besides the lag that you're looking at here. But regardless, the key insight from these plots, by the way, these dashed lines show a 95% confidence band. And the key insight from these plots is that whenever you see these correlation functions above this confidence band, tells you that you have statistically significant autocorrelation between the adverse event rates of nearby lots. We see this for dose form A and dose form B up to a lag of 4 or 5 lots. And in dose form C, we see no statistically significant autocorrelation, which agrees with the interpretation of the plots in the prior slide.
And each data point is total sum of adverse events over some period, like over a month?
No, so each, sorry, you're asking about each,
like the time series you're doing autocorrelation
so the time series is, so in this case, time is lot number essentially. So each lot represents one time step, and we're measuring the total number of adverse events divided by the number of doses for each of the lots. So it's the adverse event rate for each of these lots. So this is a time series method. It's normally applied to data that's measured with the x-axis as time. In this case, you can think of the x-axis as lot number, and the lots are ordered by the time where they are produced.
And if you go back to the previous slide, it's clear to me how you see that same information represented on these plots.
Sure, yeah. So if I actually go back here. So what we're looking for is evidence from the model that fits the data the best of whether there is evidence of sequential correlation in the adverse event rates. And what this plot is showing is that if we see that the model that fits our data the best is of the form where there are multiple hidden states that are necessary to describe the variation in the dynamics in the adverse event rates in the sequence of lots that we're studying, then we can infer that the true population generating distribution for that sequence had this sort of sequential correlation behind it. And that's what we see here.
I just couldn't see, how do you see that in this?
Oh, sorry. So I should have explained that. The lowest numbers on these grids represent the best BIC, and so the best fit essentially.
I mean, in the background here, you're trying to minimize some regularized maximum likelihood function.
Yeah.
And
right.
basically, the lowest the score is, the better your solution is. Now, what the absolute difference means, it's actually not very meaningful, but basically, if you actually look on this first column here, the numbers are, by and large, are actually much higher than the numbers on the columns to the right. That suggests that there is some at least evidence that there are multiple underlying states that can, that are being captured by sequential Markovian states, and that's kind of being confirmed by the autocorrelation kind of analysis. So.
Yeah, so just to give you a flavor of interpreting these numbers, as Rets have said, interpreting the magnitude of difference between BICs is not very meaningful. But if we just look at the difference between these two gray boxes here, if you only use a single binomial model with a single mode to describe your whole data set, then you have a BIC of around 9,000. If you allow for an extra mixture component, which you can think of as adding just the ability for there to be a bimodal distribution that describes the adverse event rates as opposed to a unimodal distribution, then your Bayesian information criteria improves by a very substantial amount. And it continues to improve as you add mixture components, even within a single state model, which is just a binomial mixture model, continues to improve until you reach some threshold, at which point adding the additional components doesn't really help you describe the amount of variation that's in the data. And in fact, the complexity penalty that's introduced by the Bayesian information criteria starts to overwhelm the improvement in the fit that you see. And you see the same pattern essentially across each one of these columns. But interestingly enough, you do see that the Bayesian information criteria does decline as you increase the number of states for these fairly simple mixture models down here with, say, 4 components or less. And that's what we're really looking for, is to see that these Markovian dynamics actually matter. And I'll talk a little bit more about that in I think a couple of slides.
But in general, the big challenge here is model selection. It's a very common problem, and I actually think that as we did that process, there is actually seemed to be a lot of opportunities, I think, to come up with more theoretically solid and maybe technically better way to select models. So, and the generic problem, you have data, you have competing models, and you want to understand which of the models is explaining the data the best. It's a very common, in various fields, it's a common problem that people are trying to solve. And
yeah, it's probably worth talking about this a little bit actually in this sort of forum, because for anyone who's interested in coming up with new research projects, like this is definitely a place where there's potentially room to grow. And there's been a lot of work on model selection for using these sort of approximation criteria, like Bayesian information criteria, or Akaike information criteria. The AIC is another commonly used metric, but these criteria are just approximations. One other approach that is possible is, and maybe you were alluding to this, Chris, is to do this whole thing within a Bayesian framework. You could take a prior over the number of hidden states and potentially even the number of mixture components per state, and do a Bayesian analysis of this, which would give you a posterior distribution over not only the parameters of the binomial mixture models and the transition matrix, but also over the number of hidden states and the number of components per state. This is another option, but this is quite computationally intensive as well. So there is a drawback to doing this. But there's not really a good in-between sort of method that is more theoretically sound than BIC, but maybe less computationally intensive than the fully Bayesian approach.
I also sort of have a question related to Bruce's. I feel like you also care a lot about the transition matrix, because it doesn't matter how many states you have, but if you're looking for correlation, you care more about how likely you are to go from one state to the other.
Yeah. So I'll get there.
Okay.
And so yes, you do care. Actually, let me just go there. I'll just go there right now, because this is a good point. So what we do see, so what we want to say to really make this conclusion that we have this sort of serial dependence between adverse event rates in our sequence is to see a transition matrix with most of the probability mass on the diagonal. So we want to see states that are highly persistent, which is exactly what we see. Now, it is, I think, possible to get a transition, to have a multiple state model fit our data best and have a transition matrix that doesn't look like this. That is possible, but I think unlikely in the presence of the autocorrelation information that we just looked at. And so you can think about the connection between a multiple state hidden Markov model and just a mixture model as collapsing these rows into sort of one, or sorry, collapsing these columns into a single column. So the more difference that there is between these columns, the more that you need the Markovian dynamics to explain the sequence of adverse event rates that we see in our data. If we had just a single state, then all these numbers would be exactly the same. It all just collapse down to a single one. The other piece of analysis that we've done, I'll talk about that last slide in a second, but I think this is also sort of interesting as a concept, and maybe a tool that others might want to use or even improve on, is the question of, okay, we have these models, or we have all these models, and let's just take one of these panels, and we have all of these BICs, and so we have fitted parameters behind each one of these models. And the question is, how different are these models really? And more precisely, the question is, there's a distribution that is induced by each one of these models. How different are these distributions? And so if you were to sample from each one of these models, would you get sequences that look very much the same, or would you get sequences that are quite different? And in particular, if we were to sample from, let's say, this model here that provides the best fit, and if we were to sample from some of these models here that only have a single hidden state, you get sequences that are pretty similar or pretty different. And this would give us confidence about saying that, in fact, this difference in fit is actually meaningful. And so this is the question that we set out to answer. And in particular, whether samples from, if you assume that the true model behind generating these sequences that we observe is a single state mixture model, what's the chances that those samples are actually misclassified as being generated from multiple state models, which is the phenomenon we observe. And it's actually a pretty simple procedure that we use to quantify this. And it comes from the concept of a misclassification index. So the probability distributions that we have are very highly dimensional, but just in a single dimension, you can visualize this as two Gaussian distributions. And really what we want to know is how large is the area, this sort of teal area in the middle here, where we're sort of confusing samples between these two distributions. Even more specifically, we want to say, let's say that this green distribution is a single state hidden Markov model, and the blue is a multiple state. What are the chances that you draw a sample from the green distribution over here, but it actually has a higher likelihood under the blue distribution? And so what we can do is we can approximate this probability by sampling. So we just sample a bunch of times from each one of our models and evaluate the likelihood of these samples under a comparison model. And what we find in that case is that if we just focus on, say, this dose form here, and we just focus on the green boxed area, we find that models that are sampled from single state mixture models are almost never misclassified as having a higher likelihood under multiple state comparison models that have the fitted parameters that we found based on our data, which gives us some confidence that the difference in the Bayesian information criteria that we observed in a couple of slides ago is actually meaningful. And this actually does translate into models that generate different samples. The last thing that I'll say before concluding is that the states that are induced by the models, the best fit models that we observed on that prior slide. So this is zooming into one of those colored squares and opening it up and looking at the estimated parameters behind those models. You can see that there is clear delineation between the states in terms of adverse event risk. So if we ignore what's in the parentheses for just a second, these are confidence intervals, we can look at each one of these lines. We can say that the mean adverse event rate in state 1 is 13 adverse events. This is all per 100,000 doses. And then it nearly doubles in state 2, and then even higher in state 3 and in state 4. We can also get a sense of how frequent each of these states are in a long-term sense via the stationary probabilities of the Markov transition matrix, and they're all roughly the same, although there's quite a bit of uncertainty around these stationary probabilities. I see the same phenomenon in dose form B, where we see a pretty clear delineation between a low risk state and a high risk state. And it's important to remember that these states are, the differences between these two states are not imposed at all via constraints prior to estimation. So the delineation between these states comes out naturally from.
I mean, Josh, did you mention that we control here for the lot size as well, right? So these are rates rather than.
Yeah.
Because one other explanation could be if you have a much larger lot for another, you could just see absolute higher number of adverse events reported with that lot, but that might not tell you that there is a higher level of risk, right? So these are really the risk rates here.
Right, exactly. I'll also mention that we.
So what does each state represent here in like a physical sense? Is there such an interpretation?
Well, okay, so this is an excellent question, and I think it gets into like a generalization of this analysis and say like what do we use this analysis for? So the natural question is like what now? Now that we have this estimation, what can we do with it? So the state by definition is just a probability distribution. It doesn't necessarily have to tie to anything physical. However, this analysis gets really interesting if it does tie to something physical. So basically what we found by talking with the manufacturer that we've spoken with is that they've done analysis that uses the number of adverse events per lot as a target variable, as your output variable, and they've tried to regress that variable on all sorts of different features that they have about their manufacturing line. And that was the sort of analysis that illuminated the dose form as a significant feature. But they haven't really found anything else that's been really helpful for them. And they actually have only been doing this regression analysis since we've been talking to them about this work, since we presented this work to them. But one potential way that you could use this analysis going forward within a manufacturer is you could, instead of trying to regress on the number of adverse events per lot, which is pretty noisy and influenced by drug-patient interaction, and as well as potentially reporting differences, you could instead try to explain the state that each lot ends up in. So with these models, what you can do is it will output a probability that each of your lots is in a particular state. And you can say, what are the features that explain why lot 102 was in a high risk state? And potentially you could discover important features from your manufacturing process, from your distribution process, that correlate with these lots ending up in high risk states.
So go ahead, sorry, just.
No, I was going to transition to a slightly.
Yeah, so I think at this point this is supposed to be a diagnostic tool that triggers investigation of trying. But my intuition that I would not be surprised if the sources of the risky states are not necessarily in the manufacturing of the therapeutic substance, but could be in things like the vials, like the injection devices, right? So the supply chain, and what can cause adverse events is not necessarily just the therapeutic substance. It could be many other things, including the management of the supply chain layer. So, anyhow, I just think that one of the things that was encouraging that this work is actually meaningful is that at least that manufacturer really put together an entire team and an entire function in the company to start looking at this in a much more serious way. So I think that at the very least their intuition doesn't suggest that this is nonsense, and they spend a lot of time on this. So, but I think that sometimes it's very subtle to understand what those changes. It's clearly not a very visible signal. It's clearly a weak signal, because otherwise you would actually violate your operating limit and quality metrics, right? Like all of this is done on things that presumably are FDA approved, right? So
but
it wasn't like
it's also true that the vials, right, are under the same controls. Like, they have light sensors and where they put the fluid in the vial to make sure everything is under control. And so it is very interesting to think where it can come.
Yeah, but I think that maybe, so my conjecture is that the definition of under control is not quite as binary as both the manufacturers and the FDA want us to believe that it is. So these under control means that it's within some sort of statistical process control range, right? That's been determined from a small number of initially produced lots, and you're either in control or you're not. And it's very likely, especially in a process that is governed by organic processes like biologic manufacturing, that it's not so binary, right? That you can be closer to your control limits in one particular parameter, and that can have a continuous effect on your product quality. And maybe some combination of process parameter readings that are near their control limits, but all within their control limits, could combine to something that's lower quality. That's just a conjecture. But actually,
does it say anything about dose C? Oh, sorry, Josh.
So I don't say anything about dose C here because the best fitting model for dose C is just a single hidden state, which is not so interesting. So
does that say something about that dose though?
Well, so it says that that you don't have evidence from this method that there is any sort of sequential dependence in the adverse event rates, which basically means that the variation, you can consider each lot as...
But the number of samples the number of lots is also much smaller. So I think that there might be also a statistical significance issue here. So this is why, because ideally, if that would be a large data set, then you would say, hey, what is difference about dose C than dose A and B? Potentially, that would be a hint. But I just think that you need to be very cautious about the results of those form C because of the relatively small number of lots that.
Yeah, I think that's true. So one other point that I want to make, Aris, related to your question, is that with more metadata about these lots, you could potentially set up a similar structure to what we're doing here with a more complex probabilistic model where these states actually do represent something physical. So for example, if we knew that all of these lots came from the same bioreactor, right, we could set up a probabilistic model that has a hidden state for that bioreactor. We could see if that hidden state produces lots that have significantly different adverse event rates than lots from other bioreactors, for example. And we can incorporate multiple different types of dependency. Right? Maybe these lots, if we know which lots are moved in the same cold chain truck, for example, you could incorporate this as well. So this structure is like the first level of something that could be improved upon by a manufacturer that has more information.
And in fact, I think that the people we work with actually showed some initial interest to do analysis like that. So basically, you actually can decompose each one of these lots to create more dependencies than we currently use. Only one dependency is with the proximity of the production date. But potentially there are other dependency structures that we currently don't see, and they might explain the results better, right? So that kind of preempted us to have a discussion with them about, okay, can we get that data and sort of try to, study that these other layers, right? So of potential layers of dependency. So
based on the adverse event database, what do you know about what happened to this product after the manufacture? I mean, it sounds like you're assuming that's completely random, but it seems like batch A could have gone to the northeast and batch B could have gone to the southwest, and that might have an impact.
That's another layer. That's another layer. Storage, yes. So I think that's another layer that you will need a much more detailed data to sort of understand in order to actually investigate.
You can find that from the FDA data, right? Because you know the location of the report location, no?
No, because you only have the country of the report. You don't have any.
You don't have that granularity. No, unfortunately, this data is not. Most data in real life are far from what you would want.
So the FDA does.
Yeah, but it is known that adverse events is connected to regional location. Sorry.
So the FDA does have a lot more granular adverse event data, but they don't share it publicly currently for reasons that I think are hotly debated.
That's another hour of discussion.
Yeah.
Of why the FDA does not share data that can help patients. Guys, I have to drop it, so sorry for leaving a couple of minutes early.
Thank you. It's great to have you, Radzif.
Thanks, Josh, and thanks everybody for good questions and good comments. Thanks.
So I'm just going to share one more slide before we head out, and unless people have questions on what I've shared so far. Does anyone have additional
question?
Sure.
Would it make sense to not include, like, if you could find all these other features and kind of factors that merged or kind of make a connection between lots? Is it worth it to not try to do that? To not over? So what I'm saying, like, you found that there might be some similarity between two lots that you can't really draw a connection to. Right.
So I think that this relates to Erez's question. So Erez's question is what does this hidden state mean? And if you figure out that you have multiple hidden states in your sequence of adverse events, like, now what? What do you do with that information? And I think in this particular case where we are assuming this structure where the hidden state relates to the production date, the next step is still a little bit complicated. Like, there's still work to do to figure out what characterizes these hidden states, if anything, across your production process. Maybe it's a particular set of production parameters. Maybe it's location of where these lots are getting distributed to, like Erez was saying. There could be a number of different sort of components that define this hidden state that we can't tell you based on our data. So what I was saying to Erez is that I think that you probably do want to incorporate some more structure into defining this hidden state more explicitly. Is if you can theoretically, if you could map all of the, if you could put into a graph all of the relationships between the production processes upstream that lead to this lot, and you can map all of those connections, then you could, with enough data, specifically determine if there is a node in this graph that is leading to higher adverse event rates than other nodes. And that would be great, because then you could isolate your problem just within one modeling framework without having to do any additional sort of discovery about what this hidden state means.
But you don't think, or it's not possible relevant, like if you added all those additional things to it, rather than having this kind of distinction between low and high, you have many more I guess nodes.
Oh yeah, so I mean
things, but they all have kind of middling problems.
Oh yeah, that's possible, right? So I think that finding a signal here is interesting, but it's not yet actionable. I think if you were to find a signal in a much more complex Bayesian network, it would be directly actionable. And so probably you wouldn't want to create a network that includes all of the possible relationships that you could include, but you probably would want to include a more interpretable, directly interpretable structure that would allow you to take action immediately. Sort of my initial sense without having done the work yet.
Gotcha. And last question, do you think this is becoming that much more illuminating for this company because you're looking things kind of in time series, like a progression, or how one lot relates to the ones before it, rather than just looking at things independently?
So yeah, I think in a general sense, the company is interested because they have only ever considered their lots as IID draws from a distribution. I don't think that this sequential nature is like particularly illuminating to them, but I think that the kernel of the idea of using this sort of Bayesian network structure to model relationships between their lots and see if those relationships relate to clinical outcomes, I think that idea is interesting to them.
Gotcha. Okay.
Josh, can I throw one more question at you?
Yeah, it's fine.
So when you manufacture these lots, right, you measure like a few dozen parameters about them. And it's really weird to make them because you keep like, it's not like you said, it's not chemistry. Like you feed these things like fructose and it kind of changes and you just kind of track all the parameters. Do you think if and when they give you access to all those in-process parameters, you're going to find some correlation between them and adverse events, between like the pH or whatnot?
Yeah, I don't know. So first of all, I highly doubt that I will get access to both the clinical information and the process parameters in one data set before I graduate, based on the pace of data sharing that I've experienced so far. So I probably won't be able to answer that question in the near future.
You need to be an LGO and go work at Amgen.
Right.
And then you'll be inside.
Yeah, I have tried that with a partner, and it's still pretty slow with clinical information in particular. The sensitivity around clinical information is exceptionally high. Anything that could potentially change the company's regulatory requirements, I think, is a hot button issue, to say the least.
What do you mean when you say clinical information here? What's the information you're looking for from them?
So the adverse event information is clinical information. So basically any data set that connects what happened in the manufacturing plant to what happened to the patient. There is extreme sensitivity around sharing a data set that links those two sets of information with any sort of outside participant, regardless of their relationship to Amgen.
Yeah, you can ask the FDA you can file a Freedom of Information Act to get some of that.
So the FDA, we are considering the FDA. So I could do that. I would rather have it come through a contract with the FDA so that we can actually get some support for interpreting their data. They have some of this information. They don't have all of it. I think that the manufacturer has a lot more information than the FDA has, but the FDA has some interesting stuff that we may try to pursue with an additional contract, but that is quite slow as well. So I guess my answer to your original question is I'm not sure if I sort of doubt that we would be able to isolate a particular process parameter from the manufacturing line that would correlate to these states or to the number of adverse events per lot. I assume that the manufacturers would have picked up on this already. However, I think that you might be able to uncover some relationship in a combination of either process parameters, but I would suspect that any relationship we would find would be closer to the distribution phases, so like the fill and finish of these lots and the distribution, especially for drugs that require cold chains. I think that those parts of the process are much more high variance than currently much more high variance because the upstream parts of the process where they're actually growing the substance are so well measured that that there's a lot of attention to variance there. But that's also just a conjecture.
Yeah, from what I've seen of cold chain, it was surprisingly pretty serious.
Yeah, I'm sure it is. It's just there's a lot more, like you're no longer in a controlled environment, right? Like you're not in a lab growing stuff. You're out in the real world. You know, stuff happens, and you have to rely on people who haven't been like growing the stuff in a lab for their whole careers. So again, it's all just a conjecture. I don't think we have any information about this yet.
Yeah, this is awesome, Josh. Thank you.
All right, we're a little over, so I will stop, but I'm happy to stay for a few more minutes if anyone has any other questions.
Thank you, Josh. Excellent.